Welcome everyone, and thank you for joining us for today's webinar titled Best Practices to Achieve Quality Pressure Volume Loop Data in Large Animal Models. This is Andy Henton from Inside Scientific, and I'll be your host for today's event. Our session today is sponsored by Transonic and is intended to review prescribed best practices for pressure volume loop research in large animal models using admittance-based PV loop technology. First, we will hear from Dr. Philip Konechny, application scientist and surgical trainer at Transonic, and following from Dr. Tim Hacker, director of the Cardiovascular Physiology Core at the University of Wisconsin in Madison. Together, they will cover a number of topics, including the essential hemodynamic equipment and technologies for pressure volume science, picking the right surgical approach, tips for catheter navigation, and most importantly, how to place the catheter in the left or right ventricle to ensure accurate data collection.
Thank you, Transonic, for allowing me to present best practices for successful PV loop data collection in large animals. My name is Philip Konechny. I'm application scientist and surgical trainer at Transonic. Today's webinar is a sequel to the best practices in small animals that we have run earlier this year. The objective of large animal webinar is to present a series of large animal best practices that will evoke confidence in your PV loop data collection while you are collecting it. When followed, the sanity checks presented will prevent the multidisciplinary team from collecting inaccurate data. I have put multidisciplinary team that is needed for this collection. I wanted to quickly explain that I will be referencing several downloaded pieces of information throughout the webinar. These pieces of information comes in various formats, but one of the most useful is 140 pages of workbook I have been fortunate to put together over several years while in Transonic's license. This book has become a close companion for many of our clients as it encompasses almost all aspects of PV science. I encourage you to download it after this webinar. I update the book for every EB session yearly with notes collected in your labs while we work together. Here, the slide value of PV hemodynamics in large animal models. What it permits is the measurement of PV relationship longitudinally at multiple time points over a long period of time, capturing instant PV relationship changes. It allows more than just cardiac MRI, for example, or longitudinal echo in that respect, that a cardiac MRI is a snapshot at one time composed together at a later time without capturing the pressure component and pressure with volume relationship. It also allows the determination of instantaneous PV relationship in the ventricles, both individually, LV or RV, or simultaneously by ventricular application. It also allows good data reproducibility, no use of radiation, for example, low initial price and maintenance. Allows also extrapolating central and peripheral hemodynamic responses reflecting respective changes, as demonstrated by the PV graph chart on the right side of the slide, capturing both and systolic elastance and respective and arterial elastance. Moving to the next slide, value of PV hemodynamics in large animal models. The table on this slide shows other very important values of PV in large animal models. On this slide, 4 cardiac imaging techniques are presented, starting at your left: echo, TTE, cardiac CT, cardiac MRI, PV admittance. Those 4 techniques I will discuss further. In the first row, I compared how the cardiac volume is currently assessed. Volumetry relies on the geometric assumptions. Also cardiac CT, also cardiac MRI, but PV admittance technique uses correct geometric assumption live. Furthermore, second row shows another value of PV, that is, it can provide information about both load dependent, but also about, as no other system currently on the market, about load independent indices of cardiac function and cardiovascular hemodynamics. Lastly, I have briefly mentioned on the previous slide, ventricle volume is directly detected as a relationship with ventricular pressure, and correlation is captured live while it can be recorded for hours, possibly hundreds of cardiac cycles. For more information, please see our workbook pages 2 and 4. Moving further, large animal PV tools and equipment. Parts of the large animal systems are presented on this slide. When put together, control unit, which is here, of PV system with a large animal license connects to data acquisition using supplied analog cables. Supplied HDMI cables connects to the PV catheter, and it all connects to the control unit to complete the hardware setup. On the previous slide, we have seen typical composition of large animal PV system. On this slide, I would like to show you two equipment types that are or you might find necessary for your good PV procedure. On the top of the slide, there's arterial blood gas measuring device. Blood gases are important to be detected throughout the PV procedure. As for example, during metabolic acidosis, metabolic acidosis will influence myocardial contractility. I would not omit arterial blood gases as a measuring tool. Below, hemochrone, another very good, it's a coagulation detection device, and it's another very good not to be omitted during your procedure. For PV cannulation, ACTs above 300 seconds are recommended. For more information, I have attached, or Andy and I attached a downloadable transonic modifiable Excel sheet. I call it supporting documentation for self-evaluation of final PV data. It contains examples of all equipment lineup and ready to go. Enable supporting a good PV work. It may serve as a modifiable checklist. When I work with the researchers on large animal PV surgeries, enable us to get ready and select all necessary equipment beforehand, before the work begins. It gives us peace of mind, I find out over the years. On the next two slides, I will discuss briefly on about the workhorse of the system, which is a PV catheter. On the right side of the slide, there are 4 pictures that describes variable segment length, ring spacing configuration. The VSL segment 1, which is the first picture, has electrical current excitation ring positioned at position 1 and 4. 1 and 4. While collecting voltage recording rings are at 2 at 3. The VSL segment 2 has excitation ring at configuration 1 and 5, while recording are at 2 and 4. At this configuration, the ring 4 became recording as we switched to larger heart chamber, for example. This goes 1 ring up until VSL configuration 4, where now 2 and 6 are recording, while 1 and 7 are excitation. As you can now appreciate, the switching between the rings enabled by just push of the button from the control unit gives user confidence that all ventricle sizes can be measured using one PV catheter. Sketches on the left at the first row shows healthy heart, for example. The PV catheter passes through the aortic valve into the LV. Ring configuration, for example, 2 and 6 recording, 1 and 7 excitation. This would be VSL number 4. Cartoon below shows LV hypertrophy situation with the same catheter inserted through aortic valve, but now using VSL segment 1 configuration. Moving on, VSL recording to ventricle sizes. On this slide, there are 2 catheters for large animal PV work. Pigtail above has its first set of recording rings spaced at 20 millimeters. Numbers corresponds with the recording ring spacing configuration always. From our experience, this PV 5 French catheter can be inserted through the aortic valve and nicely anchored in LV sizes of ventricles 45 to 75 millimeters. Below, there's a straight tip PV starting at 50 millimeters recording ring spacing. Would fit through an apical stab, for example, into ventricles of 55 to 90 millimeters long. VSL ring spacing is customizable. Please contact our team. We will work with you while helping you to select the correct size. Please collect and call or contact us. Data accuracy. At this point, we have covered the catheter sizing, the system setup to begin large animal work. We have selected rings, right catheter size. We have selected also correct large animal license, it is installed on your control unit, or is hooked up to data acquisition unit and computer. But before we start PV measurement, we need to quickly calibrate the control unit, as data accuracy comes from the calibration. There are three values researcher needs to be aware of. One is stroke volume, second is blood resistivity, and third is the heart type. To touch upon first, a stroke volume calibration factor. When a specific catheter is connected to the control unit, a default SV value will be populated based on the size and the ring configuration. However, it is recommended that the scientist use one of the following options to determine the most accurate reference possible. Listed here: echocardiography, flow probe, cardiac MRI, PA catheter. Or you can go back to the reference to the literature or use catheter default. Blood resistivity. Resistivity is a measure or property of the blood being measured. Default values of blood resistivity are entered in the control unit and represents healthy non-modified mammalian blood at 37 degrees. If your experiments involve changing blood, for example, hemorrhagic shock, I have been fortunate to be part of that model, you make measurements manually to address both pre and post blood changes states. We have measured with you in your labs in large animal models blood resistivities of dogs, swine, mini pigs, sheep, cow, and the range is between 1.4 to 1.6. Transonic also supplies blood resistivity probe that enables us to measure and add blood resistivity values. On the picture to your right, there is a blood resistivity probe, and it's shown as it measures the row by touching the meniscus of the freshly drawn blood. Heart type is another calibration parameter. ADV 500, or the control unit I call it, uses the term muscle properties to describe the ability of myocardium to conduct constant AC current signal. It is important to acknowledge this calibration parameter since it will impact how much tissue contribution is removed from measured admittance signal. When we have measured with you at your labs these values, we base this chart on your values. Normals is 800. We measured it over and over. Is 800. Infarcted 900. And we also offer a tool to measure heart type, which is option number 3, custom. You can add. For more information, please see pages 32 or 34 in the workbook. After all system is calibrated, the PV catheter will record and longitudinally collect pressure, volume data live. On my last slide, data example of load-dependent steady state comes from 72 kilo swine. I have used 7 French PV 50 to 80 millimeter spaced pigtail to collect this data. This data on the screen were collected using VSL segment 3 configuration. Also, please note, first 2 channels are ECG. Third is LVP trace. Fourth is calibrating volume. Phase is 5th. 6th is magnitude. While discussed many times during, for example, small animal webinar, the phase trace, this trace, is the live information about position of the PV catheter in the ventricle. Phase range between 1 and 3 degrees for 65 plus kilo swine is a very good number. It's a very good position. It also indicates with a swing of 1.5 degree phase amplitude. Magnitude, the overall conductance for the size of the pig is good to be between 15 to 30 millisiemens with a swing about 4 to 6 millisiemens. This brings us full circle to into the values of PV in large animal models. And also, this brings me to my very last slide before I will hand out to Andy. I have put some suggested reading for you, concentrating on large animal PV work. First I have selected one from a review paper from 2009 by Dr. Spinelli, talking about large animal model selections. Second, about admittance-based pressure volume compared to cardiac MRI. And there's another 2 articles I suggested for your reading.
By way of introduction, I'm Tim Hacker, Director of the Cardiovascular Physiology Core at the University of Wisconsin-Madison. I've been at this position for about 15 years now, and over that time we've developed 22 different animal models of cardiovascular physiology in animals ranging anything from mice to primates. We do work for, obviously, University of Wisconsin-Madison researchers, other academic institutions, and we've done quite a bit of work for outside industry, including pharma. We do measurements and imaging, both physiologic measurements of all these animal models, as well as imaging of structural and other changes in these cardiovascular models. So I sort of understand both the imaging and the physiologic side of these cardiovascular models. Currently, and we're going to talk about a little bit how we do pressure volume loops in large animals. Today, some of our current research has been focused on left ventricular function in stem cell treated infarcted swine hearts, and then we're also developing a model right now looking at right ventricular failure in a dog model of pulmonary hypertension using embolism of the lungs to create this right heart overloads. We've been using the SciSense admittance system in large animals for about 3 years now, and in small animals for over 5. I've been doing PV loops for almost 15 years in total. I'm going to give you a real brief introduction to our tools and equipment, and Philip, as Philip mentioned, he has a much more extensive guide that he shared with you as well. That's quite excellent. We use the 03500J guide wires. They're stiff enough but flexible enough to get where we need to do. We use either guide catheters or long sheaths to help deliver the catheters into the right place. And the guide catheters are sometimes hard to find because they're a little bit bigger. We've gone with the 7 French variable segment length straight tip and pigtail catheters for our work, and those require either a 9 or 11 French sheath is what we typically use to get those in. We measure stroke volume with a Swan-Ganz catheter by thermal dilution methods. In all of our models, we always stress the animals with dobutamine, so we use an infusion pump to be able to control those rates. We measure our physiologic parameters with a patient monitor, and we use one that would be found clinically, and simply because we can offload instantaneously from this particular monitor right to our computer, so we can record all of our data digitally. We always ventilate our animals and generally intubate them. And then for the most part, if we're doing survival studies, and we'll talk a little bit about more of this later, is we try to do percutaneous access. What we have the most trouble with is finding the large balloons for occlusions, and if you can find ones that are 24 millimeters and larger, those are the best. We usually borrow them from the cath labs or get used ones since they can be hard to get a hold of if you're not normally a clinical center. How do we choose our catheters? Basically, we looked at what we're going to do is going to dictate the catheter that you choose, and mostly your approach. Are you going to go from the carotid? We'll start in the right carotid, go down here into the aorta and into the left ventricle. So that's one sort of method. Are you going to start from the jugular and go into the right ventricle? That would require a slightly different method. Or perhaps an apical stab approach, or do you start from the femoral down here and then come through the aortic arch and into the left ventricle? And depending on your approach, you might choose a different catheter for each one. Also, you're going to have to look at the overall length and the internal space in your heart. Are you doing a smaller animal, a larger animal? Is the heart changed by infarction or hypertrophy with a pressure overload model? And those will also dictate your catheter size. The nice thing about the variable segment lengths catheters is that they're usually pretty versatile for most sizes of the heart. And then some comes down to operator preference. Do you prefer an over-the-wire catheter or a pigtail? For us, when we're doing terminal experiments, then in the left ventricle, we normally go in the carotid because it's easier and faster, and then we'll use a 7 French pigtail that will negotiate the valve quite easily. We can get it in there quickly, and that seems to be, we get the best data from that. If we're going from a femoral approach for the left ventricle, and this is how we normally do it for a survival approach so the animals recover quickly, we find that in pigs in particular, the aortic arch diameter is pretty tight, and it's a lot of times hard to get a pigtail around, so we prefer the straight catheters in this case. Over the wire, we can run the wire up into the left ventricle, and the catheter will follow the wire into the left ventricle, and it makes it easier. Otherwise, we're shooting up into one of the carotids a lot of times, having problems getting around these corners. If we're doing the right ventricular PV loops, we always go from a jugular approach. We come from the superior or from the top into the superior vena cava, and then we'll use the 7 French straight over the wire catheter. And we usually use a long sheath that will deliver the catheter just about to the right ventricle itself. The reason for a 7 French catheter in this case, even though it's a little bit big for our dogs sometimes, is that it's a little bit more robust, and I'll show you that we have to get a little bend on the catheter to get it the proper placement, and we find that the 7 French works just a little bit better for that. In terms of anesthesia, for our animals are always pre-anesthetized. In pigs, we use xylazine and tilazol, and you can see the concentrations that we use. This combination probably lasts about 45 minutes in a pig, and it works great. A lot of people use ketamine or other ones. Ketamine requires an awful lot of anesthetic to get a pig down. The tilazol is sort of expensive, but it's so effective that we tend to use it. They have some, xylazine in particular will depress heart rate and contractility a little bit, but usually by the time we get started with our procedures, it's well worn off. We'll go to isoflurane during the procedure, and so we tend not to worry about that so much. In dogs, we use morphine sulfate and acepromazine, and these really act more as a sedative so that we're able to get an IV running in the dogs. If we need a little extra anesthesia for the pre-anesthesia to intubate, we'll do a little propofol. Propofol is really short acting, but has some pretty severe respiratory depression, particularly in pigs, so you need to kind of be careful, be ready to intubate quickly and get ready to bag the pigs if you need to, but really effective in pigs, particularly to be able to intubate, which can be pretty challenging in pigs. And then finally, during the procedure, we always use isoflurane. And isoflurane has some issues like all anesthetics do. We like it because you can control it so well. We're always around 2%, but if heart rates are starting to rise, we can increase a little bit. If heart rates are falling, we can decrease a little bit. We have so much more control over any other kind of anesthetic out there. Even though isoflurane's a vasodilator, it has some pulmonary effects, and it definitely depresses cardiac function to some extent. But for the most part, we're always comparing one group to the next, and we try to maintain everything similar from group to group, and so even though there might be some depressive effects with isoflurane, the advantages way outweigh those effects, and so we can move on using isoflurane even though that there might be some depressive effects. You might find that different anesthetics and their hemodynamic effects might affect your experimentations more. So figure out which ones work best for you. These aren't absolute by any means. So the next question is you've got your pig, your animal down, your large animal down, how are you going to get the catheter in place? If it's terminal, we normally do a cut down of the jugular or the carotid simply because that's fast. We find that the carotid approach, particularly for the left ventricle, is the easiest and the quickest. If it's survival, we always use percutaneous access because it's so much easier on the animal. And we'll go, if we need to get into the left ventricle, we always start at one of the femoral, and it doesn't really matter if you go right or left femoral. And and otherwise, if we're doing into the right ventricle, we'll start at the jugular, and we always start at the right jugular. Ultrasound can really be helpful finding vessels, particularly in pigs that can be hard to find. They're deep, they're not on the surface, you can't oftentimes feel them, and so if you can get a probe on it, you can see it, and you can get in pretty quickly. Again, we use 9 to 11 French sheaths. We're always looking to be 2 French bigger than the catheter that we're using, and we go up to 11 French sheaths because oftentimes our occlusion balloon is so big it's hard to get in anything any smaller. We'll normally start with percutaneous access with about a 5 French catheter, and then we dial up to the 9 or 11 French sheaths to make it a little bit easier for us to get in. In the right ventricle, we use a 60 centimeter long sheath, and it has kind of an L-shaped tip, and that will deliver the catheter right to the junction of the superior vena cava and the right atria, and that sort of really guides our catheter pretty quickly and pretty easily into the right ventricle. We found this was the best way to do it, rather than we even would have trouble with the wire getting into the right ventricle, but this sheath really helps get the catheter to where it needs to go. We always cover the end of the catheter, so where the pressure window is, and the sensing and the admittance the admittance part of the catheter with a sleeve, and we've just made the sleeve. We cut off a smaller end of a sheath and then cover it, so when we insert the catheter through the sheath's diaphragm, it kind of protects it. Then we just move that sleeve back to the end of the catheter. We usually are dealing with smaller pigs or smaller dogs, and so we still have plenty of room on our catheter to move the sheath up to the top, and it stays out of our way. We do percutaneous access of the femoral vein for the Swine gans in the balloon. We found that an experienced cardiologist is going to be really valuable to show you the ropes once, in terms of how do you get percutaneous access, how do you manipulate wires and catheters into place. But once you've seen it once or twice, it's really pretty easy to do, and so, and particularly it doesn't necessarily take a lot of surgical skill in these cases to set up a pig. So don't be afraid to try this at home, I guess. This is a typical kit for percutaneous access. We use the modified Seldinger technique. Start with an 18 gauge needle here. You have the J wire and the sheath that go through. 11 blade is good to poke the skin a little bit. Sometimes in pigs in particular, in dogs, the skin's tough and it's hard to get through just with your sheath alone, so a little nick there helps. And normally the nick is small enough you don't even have to suture it at the end. We always use a heparinized saline, particularly in pigs. They clot pretty fast, and so it's good to flush your sheaths and catheters with heparinized saline to keep clotting down. And this is what it looks like. So once you can see that there's very minimal trauma here in the pig, we tend to mark the catheters with red for artery, blue for vein if we're in the same place, which we often are. And again, oftentimes ultrasound here will be effective to help finding the vein. So we'll insert the needle into the arterial lumen, put the 035 guide wire into it, and then introduce the 7th French or 5 French sheath and dial up if we need to a 9 or 11 French sheath. Once the sheath is in, you can put the catheter in. Here we already have the business end of the catheters through the diaphragm of the sheath right here, and the cover is slid back here. Again, you're going to want to have a sheath that's at least 2 Frenches larger than your catheter, just to have smooth introduction and withdrawal. And the percutaneous methods we find are great, particularly for recovery, because we do a lot of survival procedures where we're getting PV loops at the beginning of an experiment or the beginning of the model making, and then again sometime in the middle and maybe at the end. Catheter placement. So this is the key: is you have to get the catheter in the right place to get good and accurate loops. We start by putting the Swine gans into the right ventricle and into the PA. and we use pressures and fluoroscopy to guide where that goes. If you inflate the balloon on the Swan-Ganz catheters, they mostly go where they're supposed to go. They follow the blood flow, and those are usually pretty easy. If you have somebody, again, a cardiologist, point out what it looks like in 2D is what you're seeing in fluoro, and sort of get that 3D map in your head, you'll figure out really quickly how to get the Swan-Ganz in the right place to get your stroke volumes. The other note, when you're getting stroke volumes by Swan-Ganz, make sure that you note the heart, or what you're really getting by Swan-Ganz is cardiac output, and make sure that you note the heart rate at that time so you can calculate a stroke volume to put into the control box so that you can guide your PV catheter so you get the right stroke volumes from your PV catheter. With a PV catheter, we oftentimes use some sort of iodated contrast to get kind of a roadmap of where we're going. We oftentimes will save a cine loop so we can refer back to it. Once you have, we'll use fluoro to guide the wire or the sheath to desired location, and once those are close, then we'll run the catheter along that wire or down to the sheath to get it in. We'll note the number of segments in the ventricle by fluoro, and that gives us a good starting place on our control box. Otherwise, you're forever fiddling around in your control box. Do we have 5 segments in, 4 segments, 6 segments? This will save a little bit of time during your experimentation. Then we go back to the control box, and the computer will check the PV loops. We'll look particularly at the phase and the pressure. Do these loops look good? Is the phase good? Do we need to refine the location? Sometimes we find that it doesn't quite look right, so we think we have 5 segments in. We'll go down to 4 segments. Oftentimes that'll help what the PV loops look like. So there's always a little bit of back and forth at this point. Once we're pretty satisfied with where our catheter location is and the loops look pretty good, we'll run the occlusion balloon to just above the diaphragm, but below the apex of the heart. What we found is that to get good location and to get good looking loops, you kind of have to have some patience, and you really need to have kind of a light touch. You'll find that small movements make a big difference, and what happens is you'll twist a little bit at the end of the sheath, and it takes a little while to translate that rotation actually into the heart. And so if you're not a little bit patient to wait for that translation to come down, you're going to keep moving the catheter and not really finding the ideal spot. We find that catheter rotation can be really key. Sometimes you're getting the pressure window away from the cords or a papillary muscle which is banging against. A lot of times after a few uses, the catheters sometimes have a little bend or a little curve on them, and it's amazing that a 5 or 10% degree rotation in that catheter will make all the difference in the world of the quality of the loops. And so be patient. You turn it 5-10 degrees, wait for a minute or so, see if your loops look better. If not, maybe turn it a few more degrees and see if you can improve your loop. And this is sort of the tricky part. You've spent all this time prepping the animal. Now you want to see your data, but 5 more minutes of patience and refining, and you'll get really beautiful loops. Once we have the catheter in place, we're satisfied with what the loops look like, then we go ahead and do an IVC occlusion. We'll put the deflated forwarded balloon into the catheter, into the IVC. Again, we use percutaneous access, particularly on survival procedures, because of the recovery time is so much faster. And we've really find that these IVC occlusion balloons, especially because we've used them multiple times, and we just sterilize them. We gas sterilize all of our the PV catheters, balloons again and again, but the balloons get a little bit stiff, and it's hard to get them into the sheaths without having something really pretty big. We'll place the balloon right above the diaphragm, below the apex of the heart, and then we're ready to get some IVC occlusions. We always monitor physiology very carefully, and we think the physiologic monitoring is probably one of the most important things to be able to compare from animal to animal. Oftentimes you're only going to be doing 1 or 2 animals in a day, and if you're really truly comparing between from one group to the next, you have to be really careful on your day-to-day experimentation so there's not too much day-to-day variability. And the best way to do that is to control the animal physiology. So we always monitor temperature, and we're very careful about keeping our temperature in the selected ranges, both for dogs and pigs. We oftentimes use some sort of heating blanket. We use a bear hugger to keep these animals in that selected range. The respiration rates for dogs between 12 and 18, for pigs between 12 and 20. We control the respiration rate through the ventilator, and primarily what we do is we adjust the respiration rate and the depth of breathing by monitoring end-tidal CO2. And we monitor end-tidal CO2 very carefully because this can really affect even contractility if the animals are getting acidotic. So we really want to stay in this range between 35 and 45 millimeters of mercury, both for dogs and swine. It's the same for humans. Every species end-tidal CO2s are exactly the same, and you can usually hit right at 40, and that's what we aim for, to be within 1 or 2 millimeters of mercury at 40, and that works best. The other thing that we really carefully monitor is heart rate. As you know, that heart rate can make a big difference in the quality of your data, and although one of the reasons why you're doing PV loops is to be able to monitor contractility, sort of load and independent, there's still some effects, and so heart rate should be fairly easy to control by monitoring temperature and hydration levels and anesthetic levels. Dogs tend to be a little bit lower, around 75, 85 beats per minute is where we normally get. Pigs range a little bit higher, between 85 and 115 beats a minute. We try to shoot for those middle routes, and we'll wait. We'll try to adjust things to get heart rates in that range so that we can truly compare animals to animals. We monitor SpO2. Typically, we always ventilate with 100% oxygen, and so this is normally not a problem. Our SpO2s normally are 98, 99, or 100%. We do this more to see sometimes if your animals aren't ventilated and correctly or intubated correctly, they might be ventilating on one lung, these numbers would drop, or if there's atelectasis in the lungs, these numbers might drop as well. And so we kind of keep it as an overall monitoring of physiologic function. We also monitor ECG in most of the animals just to make sure that there's nothing else interesting going on. We think that, again, the main tip here is that monitoring vital signs is crucial for repeatability. We always look at pressure and heart rate trends during these long procedures to confirm stability. If one is rising or lowering, we try to figure out why. And in most cases for us, that body temperature and hydration changes are going to affect the heart rate and stroke volume more than anything. And so you have to be careful of that. And so really look at these trends and decide, is your animal stable? Am I going to be able to compare this data from the previous animal and the next animal? And what's going on? So if you have the physiologic monitoring, it's pretty easy to figure that out. Again, Philip had mentioned earlier about doing blood gases and looking at metabolic acidosis, and those things also will change. We occasionally use an iStat with cartridges to do that. For the most part, we've been doing a lot of our models long enough and don't have a lot of problems with those, and we find if we keep end-tidal CO2s in the right range, all of our blood work and blood parameters come back in the normal ranges as well. As a special consideration, I think maintaining blood volume is one of the biggest tricks in here. We say that loss of about 10% of total blood volume is pretty tolerable for good and physiologic pressure volume loops. If you lose more than that, 10 to 20% is shock, and that's data I wouldn't use. And primarily, we don't tend to lose a lot of blood. That a good vascular techniques is going to minimize blood loss. in a dog, that's even in just a 15-kilogram dog, you're looking at a 10% blood loss is almost 100 mils, and a 30-kilogram pig, that's almost 200 mils. There's no way you should be losing that much blood. Even we take blood samples here and there, but we might only really take 20 or 30 mils total, and so those are usually pretty small effects if you're careful. The one thing I do think happens a lot with these animals is that you have fluid loss. You have sort of this insensible fluid loss, and you're ventilating these animals on completely dry air, so they lose quite a lot from ventilation. The animals have been fasted overnight, and sometimes they don't drink, and so they come in a little bit dehydrated, and I think that's probably the bigger problem than blood loss in most of these cases. And then if you're doing open chest procedures, of course, you even have more sort of fluid loss, this insensible fluid loss. So we always start an IV at the beginning of the procedure and using saline or ringers. If the animal comes in really dehydrated, and you can tell, like particularly in dogs, by the quality of the skin and other measures, and you could even do it by weight, we might start some kind of a volume expander like dextrose or hetastarch. We prefer hetastarch. We tend not to use this in large animals. We oftentimes use it in small animals. We find that saline works well enough, and we're pretty careful about it, but we really watch our animals, and if they're sick, they might be even further dehydrated, and so you really want to try to standardize those things between animals to get good pressure volume data. Some of the typical physiologic values that we get, so again in dogs, we have heart rates between 75 and 105, and pigs are a little bit higher, between 85 and 115, and again, we try to shoot for the middle. Dogs, we tend to have systolic pressures between 90 and 110. Swine are a little bit lower on isoflurane at 75 to 100. Diastolic pressures are normally fairly low in both cases, 3 to 5, and if these are higher or lower, make sure that you check the balance. That's one thing I know a lot of people tend to forget when after they've calibrated the pressure part of their catheters, they don't always balance it back to 0. And so if these are odd, again, check your balance on there. With the phase, and again, the phase is the most important part in determining whether you're going to have good PV loops, and they should be low, and generally the lower the better. That means you're farther away from the muscle wall, and you're going to have better loops. The magnitudes here in the same range with the dogs, a little bit higher, the swine's slightly lower. We tend to get ejection fractions of the dogs between 60 and 70%, and swine between 45 and 55%. And again, these are the values we typically see for control animals on isoflurane. The PV loops are really positionally dependent. And so, again, I'm going to go over this in a little bit more detail here, just because it's so important to have the catheter in the right spot to get good loops. So again, in the left ventricle, we get everything close by using X-ray. And the problem with X-ray, of course, is you have a 2D image and you're trying to manipulate this catheter in a 3D space. Sometimes we use contrast to really define the space if we need to kind of figure out what's going on, particularly if we have some kind of disease models that, they might be hypertrophy, they might be dilated, just to kind of get a better idea of what it looks like in space. We're fortunate enough to have a biplane catheter, so we can actually look in 2 different planes pretty easily and get a good idea what the 3D space looks like. For the left ventricular placement is the long axis of the left ventricle, and we start from the aortic valve here to the apex and right down the middle. And the picture actually shows it pretty accurately. If you're in the aorta, it normally goes pretty straight right down. It's supposed to be again. Sometimes these catheters get a little bend on, so again a twist will help move it into the right place. And those are usually pretty easy. We'll note again the number of segments in the vessel by X-ray, and that gives us a good starting point on our control box. With the right ventricular placement, it's a little bit trickier, and we do the outflow track. So the tip of the catheter is going to be here at the PA valve, and the more proximal end, if you will be here kind of at the apex. And we don't, some people can go right from the tricuspid valve to the apex, but we tend not to get very good loops unless the ventricles are really dilated. So what we're going to do is we're going to come in with our catheter like this. It's going to bend back and then go here. So the segments are from the PA valve here to the apex here, and that's where we get our best looking loop. It's a little bit scary putting these catheters in like that because there's a pretty good bend on this catheter to come around this corner in here, and that's why we use the over-the-wire catheters. We leave the wire in. We can use the wire to guide here, so oftentimes put the wire all the way up into the PA, and sometimes quite a distance into the PA, and then once that's in there, that wire will kind of anchor the catheter where it needs to go, and then we can push the catheter along the wire to get it into the proper location. We find that breathing movement can make a big difference in the quality of loop, so we'll suspend respiration when we do our IVCs, and sometimes if you're just really frustrated and you're like, nothing looks quite right, just shut off the ventilator and see what happens with the quality of loop, and sometimes I think you'll be surprised that all of a sudden the loops come into really nice shape and you're doing very well. So here's another picture, an X-ray picture of what it looks like. So this is the catheters in the left ventricle. In this case, we have a guide sheath that comes up above the diaphragm, and then the catheter goes around the aortic arch and back into the left ventricle. You can see here an ECG cable. Here's our balloon, our IVC balloon, just above the diaphragm. The apex of the heart is here, and you can see how this catheter, this is a straight catheter with an over the wire. The wire has been pulled back here right into the apex of the heart. When we do our IVC occlusions, we suspend the respiration. We inflate the balloon as quickly as possible, sort of monitor the loop quality. During that, make sure that we're getting reductions in both pressure and volume. Sometimes you'll see once you start reducing the loading conditions in the heart, the catheter oftentimes hit one of the walls, and then you'll have a spike in the pressure. That's not the end of the world. You can normally edit those out when you do your post-processing calculations, but we prefer cleaner loops, and so a lot of times then you'll have to go back and twist your catheter slightly to find a new home for that pressure window, and keep it out of the way when the loading conditions change. As soon as we have probably 15, 20 good beats, we'll deflate the balloon. We always do at least 3 repeats, so we have plenty of data to average of these IVCs. Once we have some baseline IVCs, we always use a dobutamine challenge, and we find that a lot of times in our models, if they're a little bit subtle, there won't be a whole lot of difference at baseline levels, but we'll find that Eli's models have almost no contractility or no cardiac reserve. And so if you challenge them with dobutamine, you might really be able to further define changes between treatments. And it gives you some more data points to look at. And so sometimes, you know, when you're doing some of these animals, you're going to be doing PV loop interrogation months apart as you're waiting for the next model to come online, and so it's hard to standardize things, and this gives you one more piece of data to look at. The dobutamine challenges don't take long. You already have an IV access somewhere, so you get your infusion pump, infuse dobutamine in there, another 5-10 minutes, you have a whole other set of data. It's well worth the time and the effort. I have on this slide a typical IVC occlusion for a pig LV. You can see that we have a couple of bad beats here at the beginning, which isn't atypical, but it certainly doesn't negate the quality of the loops in any way. And you can see here these pigs have systolic pressures of about 80. We're having diastolic pressures starting at 0, and then as the animal's working, actually creates a little bit of a vacuum here. And the volumes here, again, in a fairly normal range for these animals. This was a small pig. Here's an IVC occlusion in a dog LV, looking very similar. And again, we have a couple of messy loops at the end, but those can either be edited out on most analysis softwares to get decent loops. And here we're looking at LV pressures of 110, and again, and systolic pressures of 3 or 4. And then here's an IVC occlusion with a dog right ventricle, and this dog has pulmonary artery hypertension. This is the pulmonary embolism model that we're developing right now. And again, the right ventricle pressures in this case are quite high at just above 55 millimeters of mercury, and the end diastolic pressures are often also quite high because of the disease. And we get really beautiful loops. It's actually a little bit easier to do it in these dogs with disease because the right ventricles are bigger. And so not sort of surprising to me at the beginning was we got better loops in the diseased dogs than during the control periods, and then I figured out, yeah, the ventricle's bigger, and so it works well. So but you can get really nice and pretty loops in the RV as well. I have a few additional publications here for suggested reading. We have one that we just published here with LV function in this myocardial infarcted swine model, and again we find that the contractility reserve was really different in here, and one of the good reasons to use dobutamine.
Okay, so let's start our Q&A now. And the first question is going to touch on large animal experimentation, the expense of these experiments, and how best to apply PV technology. So I think this one is going to be best fielded by Tim. And specifically, we need to hear your thoughts on, do you feel it needs to be a terminal study, or, the audience has asked, can I use this system serially in one animal? So again, how can PV science be applied in large animals most effectively, considering the expense? Maybe just share your thoughts.
So by using the same animal early, we can get baseline PV loops, either invoke the disease, myocardial infarction in one case, and the treatments, and we can measure a few times. And so by using percutaneous access, you can go in the animal 2-3 times over the course of the experiment, over the course of the month, or 2 months or 3 months that you need to collect data from the animal. And again, this is good data. It's the imaging. You're going to get a snapshot at that moment, particularly like MRI imaging. And frankly, in our institution here, the MRI imaging is about the same price as we can do PV loops in an animal. So we find it actually an advantage to use serial animals. Of course, at the end of the experiments, the PV loop analysis is the gold standard. You can alter loading conditions. You can find true contractilities, which you can't do by any other means.
Excellent. Perfect. Next question, we've had some stuff come in about VADs. Philip, you mentioned this in your introduction, and
Yes.
maybe you can expand. So the question is, how is it best to utilize PV loops, and the specific challenges surgically are related to data collection? So what can you share about basically PV loops and VAD research?
Well, over the years, PV loop, what I would say about VADs, PV loop longitudinally evaluates the support while can fine-tune the device for a specific animal to work in the synergy. What does it mean, or what does it may mean? It may gives you live warnings about if extreme cases of unloading occurs. For example, I observed a creation of micro vacuum periods during unloading. With the, let's say, unloading, you're trying to push the RPM. Sometimes you're trying to capture the pump speed, but you don't look for other parameters, and then unloading, and suddenly you have some micro vacuums created. Also, what the pressure volume allows you, and I haven't seen it in many publications, I looked through them with a fine-tooth comb, it's combining the pump flow with the load-independent indices, like, for example, creating indices that can be further characterized pump unloading in relationship to innate cardiac contractility. for example, during, I don't know, axial or centrifugal flow support. Also, pressure volume, if you collect, it helps you to detect and evaluate direct MVO2 through capture of PVA, for example, pressure volume area, stroke volume plus PE. Another very good feature to have on board. And also, I also stress out, this is a longitudinal, it's not a snapshot, it goes longitudinally, so every beat's captured. You turn the pump on, you capture the beat immediately when you're turning the pump on. You are not able to do it with echo, otherwise you will spend a lot of time to do longitudinal echo, but you don't have, again, ability to somehow store these, like store the longitudinal cine loops for over the 100 beats. This PV might help you in this. And lastly, sometimes you mentioned the surgical related to data collection. Surgically, sometimes it creates an issue when you, for example, put the PV catheter into LV and you're trying to unload the LV. But over the years, I haven't seen too many devices that create an issue in matter of electrical interference. We can always work with you on these questions, but I haven't seen too many interferences while we collect the data.
Perfect. It's a very detailed answer. Thank you. All right, next one. It's specific about core lab business. So, Tim, I'm going to direct this one at you. How can PV loops and admittance technology be used best in a core lab? So, this person has asked, Dr. Hackett, can you share your experience and approach to doing these type of large animal studies in your core?
Well, the trick is to get the PV system in your core lab.
First and foremost.
Right, and that's what we've kind of wrestled with. But usually most universities have some sort of capital exercise that they can do, and if you can gain a few different researchers that are interested in doing cardiovascular research, normally they're happy to throw in their capital exercise money at the end of the year to buy one. You'll get pretty close. Administrators like it because there's going to be multiple users for the capital exercise type equipment, and that's how we got ours. Once we have it, it's sort of like, Field of Dreams, build it and they will come. Then it's easy to get people to use it. It's a pretty easy sell. It's the gold standard for cardiovascular measurements. There are other things, and frankly, MR is popular on our campus, but it's not any cheaper to actually do MRs. They're charging some $500 an hour to get an image, plus time for analysis. We're definitely in that range or less for large animals, even far less for small animals. And the variety of data that you can get from it, you can have this PV catheter in, you can do acute interventions, all kinds of different things, and you can monitor, serially these animals. You have every data point is collected, and you can get so much more data here from, you can estimate, as Philip said, myocardial oxygen consumption from these things, work, relaxation. These are harder, like from ultrasound, which would be quite a bit cheaper. You really don't get great relaxation data from them, and you certainly don't get pressure data, which in most cases is what the body's monitoring, is what you want to be able to also monitor. And so, it really gives you an ideal window to what's happening in the cardiovascular physiology in your models. So once you have the system, it's a pretty easy sell.
Perfect. Very good. We're going to do a few more questions. What I wanted to say to the audience is, for those that can hang on, please do. Before leaving, for anyone that does need to stick to our closing at the hour, there's a handout section in your GoToWebinar menu. There is a handout, the one that Philip mentioned in his presentation. It's the Excel sheet. That is a template of sorts that you can use for your research experimentation. You can download that directly during this meeting now if you haven't. Alternatively, we'll also provide a link moving forward. But
Andy, just a note, I just put it, this is Excel sheet, so you can modify it at your lab. It's a template. It's not like, nothing is set in stone.
Perfect.
You can take it, leave it, do whatever you want. It's nothing.
Excellent.
It's really awesome. It's very complete. I was impressed with it personally.
Great. So everybody out there in our audience, get it. Get it while it's hot.
Yeah.
Perfect. So, well, yeah. Let me move on to a few more questions. For those that can stay with us, please do. So, Tim, for you, do you have any experience using sevoflurane in place of isoflurane? We've had a couple questions come in from anesthesia, and maybe Philip, you can chime in on this as well. Just thoughts, experience.
We haven't used it at all, so I don't know. We haven't upgraded any of our isoflurane vaporizers to that. It's supposed to be better.
Mm-hmm.
That's about as much as I know.
Philip, any comments for sevoflurane?
I've used it before. Very similar results I have with the sevoflurane. Again, minimal alveolar concentrations are a little bit different. Not sure about vasodilation.
Mm-hmm.
In this, don't have too many picks, which I tried, but no, I can relate to multiple data points on this.
Okay, so kind of a new option and more to discover there. In terms of anesthesia, just in general, Alicio asks, is gas anesthesia typically enough when you have your animal down, or will propofol or another drug drip be required? And again, what do you guys commonly do?
We only use isoflurane, and sometimes it really depended on your IACUC, and we go back and forth a lot of times with our IACUC
Mm-hmm.
and what the vets like and what they think is adequate anesthesia as well. And so here at our university, they let us just use isoflurane. Sometimes they like a little bit of extra analgesia, so they'll ask you to have morphine or something else on board as well. But so far we've gotten away with just isoflurane.
Okay. And Philip, again, anything, I guess maybe the question could be phrased, any particular situation where you found gas anesthesia is not sufficient?
We used propofol in a couple of preps while we did the VATs for a longer period of time.
Okay. Yeah.
It helps. We used dogs, also we used pigs. Also, we use it in our new PV implant. We're trying to gather together. We used the propofol. It helps us. In certain times. Isoflurane we used also, but the propofol, dogs was the most we used propofol on.
Okay.
Nothing to add to the how was it better or worse. Sometimes we saw a little bit of, even the propofol is marked as there's no drop of pressure. We saw a little bit of drop of pressure, but I cannot comment on the label really, but that's what we experienced.
It certainly sounds like a situational thing, and even depending on animal model and again the research model. And Tim, as you said, it's just be aware of it, how it may affect your outcome, but also whether you may need to use it. So it's a bit of an experimentation, as I hear you guys talk about it. Would that be fair to say? Yeah.
The propofol drip is like propofol doesn't last very long, so there is some ability to adjust it pretty quickly. Like isoflurane, you can slow down the drip and speed it up to adjust fairly quickly the plane of anesthesia, which I think is most important, especially comparing animal to animal. That plane of anesthesia has to be similar.
Mm-hmm. Excellent.
That's why I put the Excel sheet in, so if anything changes, just try to write it in, what I changed, how much I gave, and you have also pumps, right? So you're running the pump, so you know what's the pump number, what you ran this dog on versus the next dog. Yeah.
Sure. Okay, let's switch gears. Bruce asks about the use of fluoro and whether it is essential in PV science for catheter placement. Tim, you talked about your approach. You mentioned X-ray helping you guys, but you also mentioned that really you're reliant on the phase signal as an indication of catheter location. So, specifically the question is, do I really need fluoro? Is it essential for proper placement? What's your take, Tim, on this, and based on your experience for LV and RV, frankly?
No, you could get away without it. It'd be hard. If you're doing an open chest and an apical stab, no, you wouldn't need fluoro at all.
Right. Yep.
Then you'd be set, and so that's one way to do it. I would have trouble getting the catheter into the LV without it, but I wouldn't say it wouldn't be impossible. You have the pressure, so you can monitor the pressure window and you can see where you are in the heart. I think the right ventricle would be near impossible without fluoro. The left ventricle, I would say, yeah, it's possible. If we do it in mice, we do it completely blind in mice. And so if you're starting from the right carotid, that catheter really only has about 2 places to go, either into the left ventricle or down into the abdominal aorta. And if the pressures aren't what you like, then pull it back and put it into the LV.
That's right.
So yeah, it's all possible. And then once it's in, then we don't really use fluoro once it's in the left ventricle. We use guide by how do the loops look and is the phase right?
That's right. Soft touch and looking at phase and magnitude and loop shape. I guess it's something that has come up in past webinars and discussions, is that there's something to be said about pressure volume loop shape as well. And that most softwares permit, or I would say all softwares that people are using now permit a live XY plot of a PV loop, and that's important to have up on a monitor while you've got your hands on the catheter and doing those subtle twists, as you said, Tim. Just a small change of like a rotation of the catheter is often what you need.
Yeah.
Very good.
We don't normally look at that by fluoro. We just look at what do the loops look like when we're moving that catheter around. Do we get that? We like to have a piece of toast up on our computer monitor, and it should look like that. Yeah.
Right on. Okay, quick. This one's a straightforward one. Just want some clarification. The difference between over-the-wire and pigtail catheters, and maybe Philip, you can just comment on what is offered by Transonic for over-the-wire. Right?
Basically, every catheter, the pigtail can be straightened by the wire passing through. At the end, you may, when you receive the catheter, you may cut the tip and pass the wire through the catheter, any catheter with the pigtail end. So then you're putting the wire into the ventricle, right or left, because most cardiologists I work with, they are used to put the wire first and then slide the catheter into position, which most of you guys do. So yes, we adhere to that too. So we open the pigtail and you can do the wire first, catheter second.
And is there a specific wire or a range of one?
It's the same thing, as Tim mentioned, 0.035 J-tip guide wire we supply, but any wires smaller than that will fit into the lumen, and you can wire them anywhere in the heart or left ventricle atrial, I saw. So you can do, yes, any wire fit smaller than the 0.35 fits through the lumen of the catheter. If you have a bigger wire, however, I've seen that too, you can get stuck in the lumen, which is not, it's quite bad situation. So
yeah, you don't want to do that. We did that one.
Yeah, Tim speaking from experience. Very good. Okay, perfect. So effectively, yeah, for those that have a lumen, it can be sourced as a pass-through one into the other and put over the wire.
And the wires are much easier to guide than the catheters themselves. So if you can get the wire where you want to go, then the catheter will always follow that. Sometimes with a thinner wire, they're not always stiff enough, and they'll pop back out. And so the 035 wire is really ideal. If you have like a 014 wire that's stiff, that'll oftentimes work as well. But sometimes you'll find that you'll get your thin wire in place, and then you're starting to push the catheter along, and it'll pop the wire right back out. So the bigger wire tends to work better, but it's not. If you get a stiff 014, you'll be fine as well.
Perfect. Very good. All right, let's make this our final question. I guess it's for Philip. And Tim, depending on what's the largest animal model you've worked with, we've got a specific question about doing PV loops in cows or even larger animals like horses.
For the cows and especially racing horse area of PV research, we would work with you in terms of spacing of the recording rings, because we would need to know certain breeds of the horses, especially racehorse. They have a enlarged LV cavity, or sometimes we won't be able to capture it fully if there is no, but we can work with you if you know, or if you can measure for us the LV cavity size, and then we can build around the catheter. PV
You
catheter.
probably could get close by ultrasound looking at LV size. I would think one of the other issues would be the length of the catheter as well, and your access point.
Correct. Yeah.
So is it going to be long enough to get
Yes,
from your access
45
point
inches
to
is the length, and we can build also longer catheters, which we did also. Yeah.
Okay, perfect. So in short, it's a custom approach. So reach out to you guys, and the critical information is to have long axis length and possibly like the length of the approach through the vessels. You know, especially if it's going to be like a femoral access, it's going to be a long journey.
Correct.
Okay.
But yes, we are open to work with anybody. Actually, we do. So yeah, don't hesitate to contact us.
Perfect. Thank you very much. All right, well, let's wrap things up now. We did have more questions come in, but as always, we'll get to them in the Q&A report, and that will be available for download following this event. So I'd also like to thank Dr. Tim Hacker and Dr. Philip Konechny once again for their time today and efforts leading up to this webinar. Yeah, thanks, guys. And of course, a very special thank you to our sponsor, Transonic Systems. So the slide deck and the recording of today's event will be available soon on InsideScientific.com. And also, please take a moment to complete the brief survey that will follow this webinar. You know, your feedback is extremely important, and this, again, will help us continue to put together meaningful and educational events. So we thank you in advance. So in closing, have a wonderful day, everybody, and we look forward to having you with us again soon at a future Inside Scientific webinar.